Welcome. My name is Tyler Simmet, and I'm talking with Tania Jenkins today, a sociologist and author of the book Doctor's Orders, where she talks about hierarchy and social status in the hospital. Welcome, Dr. Jenkins.
Thank you so much for having me today. I'm thrilled to be here.
And you are a sociologist who studies healthcare systems. Where did you get your start studying healthcare systems, and what kind of systems do you study?
Yeah, so I'm a medical sociologist. I'm trained as a medical sociologist. I started out in undergrad actually studying the Cuban healthcare system and getting a taste of qualitative research in that arena. I did a master's thesis on the Canadian healthcare system and access to primary care in a universal healthcare system where socioeconomic status continues to matter. In terms of who gets access to primary care physicians. And then I came to the US to do my PhD and have since been studying the American healthcare system.
Are healthcare systems that different, or are there major commonalities among them?
Well, I think the commonalities are that they're all trying to offer care to patients. I think the way they do that differs vastly. I think the social actors that are involved differ vastly between places. I think the priorities differ vastly between places. And so those are all some of the things that I'm really fascinated by.
One of the things I loved about your book is it's an external view of the system. And it's really, healthcare is a closed system. We don't let others evaluate us because we have our own culture, our own peer groups. Is healthcare introspective enough on its own, or do we need outside help?
Well, I think that there are always ways that it's difficult to be able to see all of the kind of inner workings or inner dynamics of a system that we're a part of. There's an anthropologist, I think in the early 1900s, and I'm going to forget his name at the moment, but who said the last thing a fish would notice is water. And I think that I have that quote printed somewhere in my office that I haven't seen in a year because of the pandemic. But I think that's a good reminder to me, not only to kind of keep my eyes open and kind of try to not take things for granted, but also serves as a kind of motivation as an outsider to enter the world, in this case, healthcare, and to try to kind of understand it from that outsider's perspective. But also staying true, and there's this, desire, I think, for ethnographers like me to make sure that we're getting the story right. And to do that by, checking with the folks that we're studying through things like what we call member validation, so sharing our findings, seeing if they ring true. So making sure that, we're actually understanding what's happening, but offering a slightly, different perspective on those dynamics.
And one of the fun things is your title is Doctor's Orders. And it's a play on words saying, what is the order of status of hierarchy? But when you're talking about medicine, are you talking about the difference between a 9.8 and a 9.9? Because people feel that being a physician and getting into the healthcare system is pretty, the status there. What's the difference of status at that level?
That's a great question. Yeah, it's something that has sometimes been a critique that comes up of work or folks who study more elite segments of a society, right? Why bother studying inequality among elites? That sounds like an oxymoron or a paradoxical assertion. And I think that part of the reason it's really important is to understand that, first of all, similar patterns, similar mechanisms of inequality that we see across the socioeconomic status spectrum still exist, even at the highest echelons. I think society typically, at least growing up, it never occurred to me that there would be status hierarchies among physicians. And I think to see that similar patterns exist, even at those upper echelons of society, I think is important. I think it's important for a second reason, not only just for the experience of physicians, which, one could argue is important unto itself, but medicine as a profession, of course, has very important clients, right? Patients. And part of my work tries to assess why all of these status distinctions and competitions within medicine, why they matter for patients as well as physicians. And so I think that's part of the reason, is to understand how dynamics happening within the profession matter for those of us outside the profession.
It's also interesting where you go through the history to say that some of these may have a historical origin that no longer make any sense. And if you move a system from outpatient to inpatient, they're still going to do it the outpatient way and not going to organize it. With the change, how do you reshuffle a system and rethink the system?
With what kind of change do you mean?
So with medicine changing, with us becoming more specialized and more segmented, how do we get people to think not only for their own small section, but how it relates to the larger whole?
That's challenging, right? Because I think part of the argument I make in the book is that winning the game in medicine often means hyper specializing in a tiny organ system oftentimes, or being a physician researcher in different ways. And so the way the reward system is set up in the profession, at least in terms of salary and prestige, seems to be kind of at odds with what, in some ways, the healthcare system needs most from physicians, right? And so in order to kind of be able to accommodate some of these changes, I think would have to involve a reorganization of the rewards system within the profession, which of course means taking rewards away from people who are enjoying those rewards and are oftentimes in positions of power as a result of enjoying those rewards. And so it's an incredibly difficult thing to do.
Well, I'm going to push back a little bit, because within a university hospital, yes, being a left-handed flexor tendon specialist is going to be highly valued. But within the community, if you're on an airplane and someone's sick and they say, is there a doctor on board? And you say, I'm a left-handed flexor specialist, you don't have much prestige. And particularly with first-generation Americans, people who are first time to college, they look at their position within a community where primary care has tremendous value. The knowledge itself gives you abilities that have value to itself. So I guess I'm trying to break it down into, there are multiple tribes and multiple systems at play. Are you looking at it from the dominant system of the hospital or the structure that controls it, or the individuals?
Yeah, I should say I completely agree with you. I don't mean to suggest personally that I think the pinnacle of medicine is to be that specialist in the left part of the thyroid or whatever it is. What I do mean to suggest is that I think a couple of structural factors baked into both the profession and medical training do reward certain outcomes more than others. And so there are a couple of factors, one of which is not only the salaries that tend to go up the more specialized you go, but also the amount of debt that medical graduates are incurring along the way. And that was one of the major factors, one of the perhaps the only constraint that USMDs in particular in my study faced when it came to specialty decisions, was what specialty will allow me to pay back my debt as quickly as possible. The other constraint that they faced was pressure from their peers and their mentors and their communities to some extent to keep every door open. I can't tell you how often I heard that, and to go as far as they could possibly go. And oftentimes that is conceptualized within the profession as going to fellowship or going to subspecialize. So I don't mean to underplay, I think, the role of, especially from a community perspective, the role and the importance of a physician who is working in the community and has a broad spectrum of knowledge and applies that knowledge to their work. I think that the professional rewards are such that oftentimes they'll encourage a lot of that subspecialty.
And bringing it back to the book and what you studied, you do try and differentiate the USMDs in terms of preliminary categorical years, what their goal was. Do you see the MDs as one tribe? Because you have community-based MD schools, academic MD schools. I guess I'm getting more granular and I'm wondering, is it one tribe and what are the lines?
Yeah, definitely not one tribe. I think I had to make some analytic decisions in the book. And one of the decisions I made was to create this category of USMD versus non-USMD. And non-USMD, I openly acknowledge is a heterogeneous category comprised of three large, very different groups of physicians, right? US international medical graduates, DOs, and non-US citizen international medical graduates. I did that for a couple of reasons, partly because that's how training will often get segregated, right? So it's not perfectly segregated this way, but a lot of programs will staff either large numbers of USMDs only or large numbers of non-USMDs. I did that partly because that's how the match process gets conceptualized. Even at the fellowship level, match statistics are reported along MD senior versus other line. I checked this was true even for 2021 after the merging of the accreditation systems. And I did this partly to really be able to parse the differences between these large two groups of people. Are there differences within them? Absolutely, absolutely. I think a graduate from Harvard University compared to another USMD school has very different opportunities in the match process, for example, oftentimes, not every time, but oftentimes. There is racial inequality among USMDs, there is class inequality, there is gender inequality, there are different orientations towards specialty and non-specialty. So I don't mean to suggest that they're a heterogeneous group. I made that decision, like I said, consciously to try to leverage, to get some analytic leverage on the differences between these two groups.
Interesting. And the three groups, I guess 4 groups, you broke it up to USMD, USDO, USIMG, and International IMG.
Mm-hmm.
You come from Canada, where DOs are very different than DOs in the US.
Yeah.
How did you learn about DOs in your research?
It's a great question. It took me by surprise. I think when I first started my field work, it took me a long time to realize. I started my fieldwork at a small community hospital that I call Legacy Community Hospital. And I noticed that maybe about 25% of the house staff were non-US citizens. But I didn't realize that the other 75% of the categorical house staff were either USIMGs or DOs, in part because in Canada, it's becoming more common, I think, for Canadians to go abroad to study and come back. It's certainly more rare than it is in the US. And as you said, DOs or osteopaths in Canada aren't allowed to practice medicine. I didn't even realize that they were a professional category within the US. It probably took me a few months and a lot of studying of the roster of residents for it to dawn on me that, there are these other providers, folks who had different trajectories into the profession. And it's interesting that they're all here in this one program. Where are all the USMDs was the question that occurred to me. And as I started doing a bit more research and noticing that the large university hospital nearby was staffed exclusively by USMDs or almost exclusively, the puzzle began to form for me of, why does this segregation exist? How does it come to be? And how does it impact the training and the mobility of these trainees in these programs.
Well, one of the differences between DO training and MD training is DO is trained in a distributive model. So they'll train in multiple community hospitals. And the thinking from the educational perspective is let's embed the education in the person, not make it pure sociocultural learning where they learn how it's done at this hospital so they can work at a hospital like this hospital.
Mm-hmm.
Do you think that comes through in the mobility of the DO students to train in a community hospital or multiple different areas?
I think so. I mean, I think that for better or worse, these community trainees, at least the DOs that were in the categorical program, were confined to training in this particular program. That was true of not only the DOs, but the residents as well. So they had the option of doing electives in other programs. And some of them exercised that option, but their training per se was really confined to this one hospital. So I can't sort of really speak to how DO trainees versus others were able to kind of fluidly work through different systems. But I can say that I think that they, that a lot of them enjoyed the community hospital kind of environment, and really enjoyed working with patients in that kind of environment as well.
And in looking at the USIMGs versus the international IMGs, that seems like a clash of cultures in that they really have very different backgrounds and trajectories. Do you see them coming together with their interests to advocate for change or to work through the system?
Yeah, I touch on this a little bit in chapter 6. It's a chapter called the Navy SEALs and the National Guard. The quote, right, came from a USMD describing the difference between training in a university versus community hospital. I did not see a kind of coming together of the residents at Legacy Community Hospital. Well, let me be clear. I saw great camaraderie between the residents. I think for such a diverse group of individuals from a wide range of training backgrounds, training traditions, different countries, different languages, they got along very well, were very respectful of one another, and I think saw and admired tremendously different skills between the different residents. So what I will share is that there were many times that afternoons in the residence lounge where MDs would ask DOs for treatments, for manual treatments, for various aches and pains that they were experiencing, and were really interested in kind of learning about their training and their backgrounds. And so what I observed was admiration and respect, not a kind of othering or differing between the residents. But with respect to international medical graduates, be they US or non-US, I think their trajectories into the profession were sufficiently different to have different experiences in terms of their different experiences with the system. I think non-US citizen international medical graduates, many of them came to the US looking to be in the place where the guidelines are written, where the textbooks are written, to be, some of them called it the Mecca of medicine, and knew that about 1 in 2 applicants succeeded in that quest. And so they very much viewed themselves as just fortunate to be here, and understood the system that I think de facto, not officially, but de facto prioritizes USMDs as fair for that reason. Similar systems happen in their countries where nationals from their countries are prioritized over international trainees of various kinds. And so they felt very much sort of fortunate to be here. I think US international medical graduates had a slightly different experience. Many of them felt very fortunate for similar reasons. They knew that a lot of their colleagues hadn't matched. A lot of them hadn't made it through medical school. And so there was a pride and a kind of sense of accomplishment that they had made it. There was also, however, very much an internalization of a sense of individual responsibility, that they internalized this broader ethos of, with enough hard work and dedication anything is possible. A number of the Caribbean graduates I studied had aspirations of going into surgery or anesthesiology or radiology. Some of them came pretty close and did wonderfully well on rotations, but ended up in internal medicine more by constraint than by choice, and very much internalized that outcome as being the product of their doing. That it was very much sort of that by virtue of, with enough hard work and dedication, by that kind of logic, then if you don't achieve your goals, it's because you didn't work hard enough and didn't want it enough. And so
the
for
school
those
gave
reasons,
them the ticket, but they had to get there themselves.
yeah. And the belief that USMDs were getting there by themselves. That was a very important part of that belief system, that USMDs are achieving these positions, whatever it was that they were wanting to achieve, through their own doing, as opposed to any kind of systematic advantage. And so for that reason, USIMGs and non-US citizen IMGs came from very kind of different places. And so I wasn't observing a kind of, banding together against the system that treats them as inferior for that reason.
One thing you did very well in the book is describe the structural inequalities of a community hospital education from a university-based medical school education. And you did it qualitatively with stories, with examples. Is this the kind of assessment we need in medical education, or should the assessment be switched around or include other aspects?
Well, I think part of what I address in the conclusion is that in an effort to standardize or establish standards for medical education, which I'm all for, by the way. I think we should have standards to make sure that our trainees are adequately being trained, but that in a kind of quantified standardization process, standardization does not equal equality. So to say that two programs meet the standards, whether it's the ACGME standards or the ACOM standards, I think qualitatively, if you were to compare those two programs, even though they might on paper check off those boxes, qualitatively they might not experience, and they may not translate to the same training environments. So what I mean by that, one example is that Legacy Community Hospital was affiliated on paper by, through an accreditation requirement to a medical school. But that affiliation was very much a pro forma affiliation. The medical students wore a badge, emblazoned with the med school logo on it, but they weren't even allowed access to the library resources at that medical school. They could only use the library resources that hospital could afford. So, by quantifying medical education outcomes in some ways, that's important. It's important to be able to kind of get a big picture view of what's happening. I think a qualitative assessment adds nuance and complicates that quantitative big picture assessment. And in some ways, I think it could be a useful approach to getting a better sense on the ground of what training actually looks like in these different places.
And it is something we are working on in medical education, trying to get a better handle on, because we know that the way into medical school is the MCAT. And people question, is the MCAT a test of privilege? Does it show, you go to a bad high school, you're going to go to a bad college. You go to a good high school, you go to a good college. Is the MCAT that way? And if the tests all the way through are achievement tests, sure, the MCAT will tell us how you're going to do on your boards in medical school, but is that the right assessment? What are your thoughts on the MCAT as a differentiator, or other differentiators in the people that you worked with in the different groups?
What I observed was that some groups had much more help playing the game, as they put it, than other groups. It was described to me quite early on in my fieldwork at Stonewood, this idea of playing the game of getting into medical school, right? Checking off all the boxes, whether it's getting a good MCAT score or volunteering. One of them joked it's curing cancer. Doing all the things you need to do, but also separating yourself out and distinguishing yourself, right? The MCAT is a critical part of playing the game. But what I found was that USMDs typically came from higher socioeconomic status backgrounds. They came from families, even if they weren't wealthy families that valued education and that were able to provide support and resources to those eventual USMDs going through the various, from kindergarten onwards, the various sort of training steps that they took. So some people get more help than others. And I think the MCAT is kind of often conceptualized as just an objective measurement of skill. And to some extent it measures skill. But I think what it doesn't capture necessarily is the help along the way that certain groups in society systematically get more than others. And so that was part of the goal of the book, is to sort of shed light on what I call the kind of tailwinds, right? You could think of these as tailwinds that are kind of pushing certain students towards higher success versus the headwinds that other students are experiencing that aren't captured by these kind of these quantitative scores on tests sometimes.
Interesting. The other differentiator or filtering point you brought up in the book quite a bit was the match, both the fellowship match and the residency match. How do you see that evolving or changing, or how is that affecting students?
The match is it's a fascinating institution to this sociologist. It emerged as a response to interns at the time in the 1950s, really being quite unhappy with the very informal way that residency positions or internship positions were being meted out at the time. It sounded like a very stressful affair where they were given exploding offers and forced to kind of commit to something under very tense conditions. And so the match was a response to that, to say, hey, let's give everybody as much of a chance as possible. And in fact, improved access for women and ethnic minorities to be able to access GME. And so in some ways it's been, it has had an equalizing influence on the profession. I think that the match as an algorithm, I write this, is only as objective as its inputs, right? And those that are putting in those inputs. And I think that it is a system that seems, again, on the surface and has the potential to be very meritocratic, when in fact, I think is influenced in large measure by a whole bunch of different societal factors. And I think that it's a process that is especially fraught for programs as they're making these decisions. I think, as I shed light on in chapter 2, that the decision of who to rank where isn't just a decision about who the best residents would be for that program. It's also a decision about how that match list will make the program look. And that's just one factor of many that are playing out in the match. And so I think as an institution, like I'll come back to it, it's really fascinating. And I think that I don't want to throw the baby out with the bathwater. It certainly has played a role in making opportunities more available within the profession. But I think it also has the opportunity to exacerbate certain kinds of inequalities.
Interesting. And just to make the picture complete, we can't talk about medicine without focusing on other professionals also practicing, NPs, PAs, DPTs, and others. How is that going to affect standardization of education, credentialing or micro-credentialing as we know it, and the status hierarchies?
Yeah, I think it's interesting. I think that as a whole, and we can discuss whether medicine is one whole profession or whether it's many different professions, but I think as a whole, medicine has this role, right, of being in a gatekeeper position vis-a-vis a lot of the paramedical professions, right, that you just mentioned. And so medicine continues to be the professional body that decides, you know, who gets to do what and you know, under what conditions. So I think as medicine becomes ever more credentialed, it's not surprising to me that a lot of the paramedical professions are also becoming ever more credentialed. We're also seeing that, I think, across the board, that there's just this proliferation that sociologists of work and education are noticing, a proliferation of degrees and degree types over the last few decades. So that's not surprising to me. At the same time, yeah, I'll use a term from my homeland, from French Canada, or from French in general, you know, plus ça change, plus ça reste pareil. So the more things change, the more things stay the same. I think as a lot of paramedical professions become more credentialed and that those credentials become ever more complicated, what isn't changing substantially for the most part is the relationship between medicine and those other professions, that medicine remains dominant and remains in the driver's seat when it comes to deciding who gets to do what and how the cookie of medical work gets to be crumbled so that certain groups are able to do certain kinds of work and others aren't.
Thank you. Interesting thoughts. Other things you want to bring in from the book before we close out the interview?
No, I think I'm hopeful that the book has shed some light on a topic that is probably very familiar to physicians. I mean, it's a topic that is in some ways widely known about and widely understood, and perhaps not quite so often spoken about. But I hope that by being that outsider, that in some small way I've been able to shed, you know, a different light perhaps on some of those more familiar conversations that are happening in the profession.
And I want to thank you because you really have clarified for me some of the status differences, where they come from, and actually some of the qualitative differences that we need to focus on so that there really is equal education, equal outcomes. And I highly recommend the book. It's Doctor's Orders, Making of Status Hierarchies in an Elite Profession. So thank you, Dr. Jenkins. Appreciate your time and wish you the best.
Thank you so much. Thanks for having me.